Thanks very much for the opportunity to be here with you today. And also to the organizers, thanks for arranging this subject, opportunity to have a conversation on this subject, and Carol, to you and the school. It isn't just the healthcare issue that you've dealt with, it's energy, transportation, many societal and pressing economic issues. I think the Ivey School has brought great leadership in that regard. So I guess I have the challenge and the benefit of going last. The challenge is all the good things I wanted to say have been said, but in this case, much better than I could have. And the benefit, of course, for me is I'm going to try to pick up on many of what my colleagues have put on the table to try to, I guess, punctuate some points in terms of Ontario's journey and Ontario's path with respect to innovation and how it manifests itself and how it will manifest itself with respect to the healthcare spend and the healthcare outcomes in Ontario. So it is meant to be short, so I could cover several subjects, but I want to start by picking up on the definitional aspects that Peter identified at the outset. And I would agree that innovation manifests itself and is defined in many different ways, either through productivity, I guess, if you're an economist, quality if you're a clinician, and I'd like to use those two interchangeably and to give you some examples of how Ontario is trying to go down that path and use evidence as a key tool in getting innovation adoption, or the equivalent of commercialization in the healthcare sector of innovation, of research. And I won't dwell on the fiscal imperative, but it is an imperative. Derek and others, I think John spoke a fair bit about that. Michael as well identified that in terms of the impact that chronic disease, especially diabetes, will have on the costs in healthcare going forward. Yes, 46% in Ontario today, left unchecked, arguably 70, 80, 12 years from now. I think that profile or that trajectory is the same in virtually every province, give or take a few points. The fact of the matter is that that has an obvious impact on crowding out, and the objective or directions I've been given is to get a reduced growth curve in healthcare spending. So 8% growth, perhaps to 5%, culminating in 3%. I think if we can land somewhere between 3 and 5, as Derek's colleague has mentioned in the past, Don Drummond, you have a fighting chance to not crowd out other spending, especially when the next largest education spending is in the 20% range. So, it doesn't take much to figure out the math. And then I guess the last piece on the fiscal imperative would be interest on debt. And Ontario's identified a 5-year trajectory out of deficit. That means adding to the debt load, and therefore interest on debt is a significant portion of government spend, $10 billion in the 11-12 fiscal year. That's a large number by any measure and by any comparator. So what is Ontario going to do on the path to try to embrace innovation and deal with the fiscal imperative? Well, one or some of those initiatives will be through improved quality. Many have said, I'm quite new to the sector, many have said to me, both practitioners and leaders, that there's enough money in the system, it just needs to be spent in a manner that aligns with better quality. I don't think more effective care has to be more expensive care. And that's driven home by many examples of changes that Ontario is trying to put in place. Well, one of the aspects of innovation to me in the healthcare sector is how do you get the adoption of evidence? And lots of guidelines. And the challenge with guidelines or best practices is they're optional. And if you have the time, if you have the inclination, if you have the, I guess, also the time and inclination to pursue that research and to understand it and to bring it into your organization, no matter what level you find yourself in the health sector, then you'll benefit from that innovation. So the path that Ontario is trying to take is to accelerate the adoption of evidence as a form of that commercialization, I would suggest. And one of the ways of doing that, by way of example, And to a few of the audience who've heard this before, I apologize. These examples are probably getting tired for you, but they are illustrative of the fact that guidelines have been in place for some time, and yet we've taken time to adopt those guidelines, and we want to accelerate that. So last year in Ontario, 49,000 ECGs were undertaken in advance of cataract surgery. 15 years ago, evidence showed that for most people, that's an unnecessary intervention, really, because it is an intervention. And so we've just eliminated the ability to undertake that in most circumstances. Where clinically necessary, it will be provided, of course. So just one small example, vitamin D testing and the frequency of testing. In 7 years, that testing has gone up 2,500%. That's about a $225 million cost to the system. And evidence suggests, in most cases, some people need that testing on an annual basis, but in the majority of cases, unnecessary. So, small examples, I grant you, but they're not small in their magnitude of impact. And I just don't mean the financial impacts. I mean on the ability for all of us as consumers of healthcare on the demand side of this equation to accept that we need to take advantage of the evidence to drive innovative change. And innovative change is about productivity in the examples I've used, but it's also about quality. Quality of care, meaning the amount of radiation you receive is perhaps reduced, and therefore there's a health benefit. Another area that, as part of that evidence adoption is to create an organization called Health Quality Ontario. And I don't mean more bureaucracy. What I mean is coalescing the quality activities taking place in primary care, acute care, and in the Ontario Health Quality Council, including the Ontario Health Technology Advisory Committee, and bringing them all together, reducing their administrative burden, but accelerating the development of standards of care, a couple of examples I used, and beyond. Creating quality improvement support for organizations, that adoption element, so that you can accelerate the adoption of new standards of care. They won't be guidelines. They will either be changes in funding structure with hospitals, or they will be items that will no longer be on the fee schedule, with the cooperation of practitioners and professionals in the sector. And then monitoring and reporting. Evidence has shown that just doing one of those by themselves is inefficient and ineffectual with respect to driving change and adoption of innovation. Secondly, the government will require, starting with the hospital sector, will require quality improvement plans. So through surveying of staff and employees, through understanding the behaviors and outcomes that take place through various indicators in a hospital environment, hospitals will be required to post quality improvement plans on an annual basis. Executive compensation will be tied to that on an accountability point of view. And it will be made transparent to consumers, to users of healthcare. Again, quality changes will need to be identified. They will need to be undertaken, and that will be on an annual basis. And Health Quality Ontario, this organization, will report on the effectiveness against indicators about hospitals' performance in the area of quality improvement. We're also trying to work with the medical devices community in Ontario to help with pre-market assessment of their technology as another form of adopting innovation in medical devices. Again, many companies in Canada, but Ontario for certain, will say, if I can't sell at home, I can't sell abroad. So trying to work with those companies, both domestic and internationally resident in Ontario, to do pre-market technology assessment. Very nascent activity that we have with them, but we believe, and I'm led to believe, that maybe the first of its kind. Derek mentioned global budgets as part of the contributor to not creating enough, I guess, my words, adoption of evidence and penetration of quality into the system. So patient-centered budgets or activity-based funding, activity-based costing, apply whatever lexicon we like. Ontario has that today in our wait times approach, in specific funding for specific programs that are tied to patient outcomes. But in hospitals, we give them a global budget. We create no incentive for hospital leaders to work horizontally across the spectrum of care and shift care into the community, get people at home where they want to receive care and where they want to convalesce, rehabilitate, and to improve their health. So we will move to have a patient-centered or patient-based payment model that will begin, and over time, I believe we're going to need some form of global budgeting for other costs associated with infrastructure, with research, etc. But nevertheless, a commitment to move forward on a patient-centered approach, such that the episodes of care tied to quality, again, help for innovation adoption. I'd be remiss if I didn't speak about electronic records and electronic health. So I do agree that much has been done. I do agree that some time has been lost. But Ontario has, I think we're number 2 behind Alberta in terms of the penetration of electronic medical records amongst physicians. Hopefully by the spring there'll be 60% of primary care physicians, almost 6,000 primary care physicians with electronic medical records. What we are not pursuing is at some given date, you'll turn a switch on and we'll all have an electronic health record. Electronic health records exist today. We have electronic health records for several million children today. We have diagnostic imaging being shared around the province. We have telepathology, telepsychiatry taking place so that the movement of individuals on diagnostics in the north doesn't have to take place, or the immediate response is, well, you better get to a center to get that diagnostic image examined more effectively or properly. So I'd just like to end by saying that this is a much needed set of transformations, no question about it. The case for change, I think you all accept to be quite clear. I think that harnessing innovation and driving increased quality and productivity measured through improved health outcomes is the task and the path I believe that all provinces are on and need to be on. So I think that journey is one that needs to be taken, and hopefully you have a glimpse into what journey Ontario is about to embark upon and continue upon as well. And I thank you for your attention.